Hi, Miss Nikki here. Welcome to Chapter 19, Part 2. We're going to talk about cardiac conduction system here. So, the cardiac conduction system. What's initiating or triggering the cardiac muscles to contract? This conduction system initiates and conducts electrical events to ensure proper timing of contractions. So these are specialized cells that we're going to see in just a second that are going to generate action potentials, but they do not contract. So that's why they're often called non-contractile cells. So these non-contractile cells are going to generate an action potential that's going to talk to the cardiac muscle fibers and tell them to contract. So it's going to initiate this cardiac muscle cell to actually contract. This is the sequence or the cardiac conduction system. We're going to learn about an SA node, an AV node, an AV bundle, sometimes still called the bundle of His, and then these Purkinje fibers that are going to wrap around and through the walls of the ventricles. So all of this in yellow, here's the SA node, here's the AV node. We can see this bundle as it goes down the interventricular septum and wraps around to the right and left ventricles where the cardiac muscle is located. So we're going to walk through this system, but these nodes are going to generate the action potential and initiate this cardiac muscle in the walls of the chambers to contract. They want to make sure that we understand that the brain does have innervation in the heart. So you're going to have the cardiac center in the medulla oblongata. Remember, this is brain stem. You're going to have a cardio-acceleratory center and a cardio-inhibitory center. These are going to receive signals from baroreceptors. We haven't really talked about these yet, but these are going to have something to do with blood pressure. They monitor blood pressure. You also have chemoreceptors, which are going to monitor the amount of chemicals. Let's think of things like the amount of CO2 in your blood or the amount of oxygen in your blood. And these can send messages on sympathetic or parasympathetic pathways. So think of the brain as modifying, not initiating cardiac activity. So I like to think of the fact that we have two ways, right, of causing the heart to beat faster or slower. So within the heart itself, right, so inside the heart we have those SA-AV nodes. So we kind of have an internal electrical system, and then we also have nerve coming from the brain, either sympathetic or parasympathetic. And there's kind of a better image coming up in a second. Just to go back and make sure we remember parasympathetic. Parasympathetic is rest and digest. Parasympathetic, rest and digest, it's going to decrease heart rate. Sympathetic is fight or flight. And if you're doing fight or flight, you are actually increasing heart rate. Here they're showing you the actual nerve, so we can see the vagus nerve is coming down, vagus nerve right and left side. We can see that there are cardiac nerves. We can see that these centers, this cardiac center is in the medulla oblongata of the brainstem. They're showing the location of some of the receptors that are monitoring the amount of chemicals, or they're monitoring the pressure. So here they're showing you the SA node, the AV node, the bundle, and the Purkinje. So basically there's an internal system, and then there is also an external system. So they talk about this as initiating, and they talk about this pathway as modifying. So modifying increased heart rate, decreased heart rate. These SA node and AV node, they're actually starting or initiating the contraction of the muscles of the heart. On this slide, they want to drive home the point that the heart contraction involves two events. So the conduction system, this is the nodes, right? So the SA and the AV nodes, this conduction system is going to initiate an action potential. That action potential is going to target the cardiac muscle cells, and that's going to induce them to produce action potentials and eventually contract. This is happening first in the atria and then in the ventricles. The SA node can initiate the heartbeat. If you remember resting membrane potential, if you have a cell, the inside of the cell is going to be negative resting membrane potential. The outside is going to be positive due to the ions that are extracellular, right? So the resting membrane potential, in this case, in these nodes, the resting membrane potential is minus 60. They do not have a stable resting membrane potential. So they are called autorhythmic cells. They are spontaneously firing. Basically, these nodes are going to do depolarization, repolarization. And then immediately after repolarization, they're going to do depolarization again. And then they start to do repolarization, they automatically do depolarization again. So they're never at a continual resting membrane potential. They immediately go from depolarization to repolarization to depolarization over and over again. They can reach threshold without stimulus. There's nothing telling this SA node what its job is. The SA node is just doing the same thing every day, all the time, right? Depolarize, repolarize, depolarize, repolarize. Your brain can send a message and tell it to speed up or slow down, but internally, this SA node is just spontaneously firing. The normal heart rate will be about 75 beats per minute. So this is the SA node initiating an action potential, that message going to the actual cardiac muscle contractile cells, right? So the cells that are actually in the ventricles and the atria that are going to contract. So about 75 beats per minute. We do have something called vagal tone. So this is the parasympathetic activity coming from the vagus nerve, and it keeps the heart at a lower resting heart rate. So if it was just up to the SA node, it'd be a little bit faster, but we do kind of, just like we keep our blood vessels partially contracted, this is going to lead to having the resting heart rate be a little bit lower. This image here is probably better than my drawing, right? Here we are at negative 60, and we're going to go up to slightly above positive, and then we're going to come back down to negative 60, and you see how it immediately goes back up into depolarization. So there's never this long lag time where this SA node is at rest. This is what they mean by autorhythmic. This is what they mean by spontaneous. It just automatically happens. It's just going to happen over and over and over again. So the whole point of these autorhythmic cells are to generate an action potential, and that action potential is going to trigger the actual cardiac muscles of the atria and the ventricles to contract. Up here, they're showing you that here's the cytosol, so this has to be inside. And this is the interstitial fluid, so we know this has to be outside, right? So intracellular versus extracellular. So this node is a cell. The inside is at negative 60. You're going to see this gate open. Sodium is going to enter the gate. It's going to enter the inside of this SA node, this cell, this nodal cell, and it's going to cause the inside, the resting membrane potential was negative 60. We're adding positive sodiums, and so that number goes up to negative 40. And then we're going to see a calcium channel open. So now this is extracellular calcium, or calcium outside of this nodal cell. The calcium is going to enter, and we're going to see the inside of the nodal cell go from negative 40 to +1, +2, +3, somewhere in that field. Then both of those gates are going to close. You're going to see the potassium channel open. So we're at positive. We generated an action potential. We're going to see the positive inside of the nodal cell go back down to its original resting membrane potential as the potassiums are exiting this nodal cell. So we've gone from negative 60 up to positive 1 or 2 millivolts. Then we go back down to negative 60, and then it does the whole thing over again immediately. So the repolarization actually triggers this gate to open and starts the initiation again. Starting at the SA node, the action potential is going to spread to the AV node. The action potential travels through that AV bundle to the Purkinje fibers, and remember those Purkinje fibers are in the ventricles. So the action potential spreads through the ventricles very rapidly, and gap junctions allow the impulses to spread through the cardiac muscle fiber cells in the ventricles. Remember, these are communication channels. This allows for the two ventricles to contract almost at the same time. So I'm kind of asking, why is this important, right? We have our right atrium, we have our left atrium, left ventricle, right ventricle. Remember, we want both of these ventricles to contract at the same time so that we can push from the right out to the lungs, and we can push from the left out to the systemic or the body to the aorta. So they both have to contract at the same time. So we want that node, right? We have the SA node up here, then we have the AV node, then it travels down the bundle, it wraps around the Purkinje to tell both of these ventricles to contract at the same time. That allows the most efficient flow of blood from the heart into the vessels. So this image is probably a little bit better. You can see the spread of the action potential. So that action potential that's generated by the SA node spreads via gap junctions to the cardiac muscle cells that are in the walls of the atria. So the SA node action potential is what you're seeing spreading in red throughout the cardiac muscle cells that are actually going to contract. So remember, this is a non-contractile cell. And the ones that you see here in red, these are the contractile cells, the ones that are actually going to contract and generate pressure. So you can see the SA node has now talked to all of the atria, and the SA node is now, the action potential from the SA node is going to reach the AV node. And then it's going to pass down the bundle, wrap around both of the ventricles. Image 3 here, you can see the AV bundle is then passing the message. So now AV bundle sends the message down to the AV bundle. And then the AV bundle splits right and left ventricle muscle. So the Purkinje fibers, the action potential is going to spread via gap junctions between the cardiac muscle cells throughout the ventricles. So they're telling you the action potential that was generated in the SA node, AV node, that traveled down the bundles, that traveled around the ventricles, Purkinje fibers, that action potential is now talking to all of the cardiac muscle cells in the ventricles and telling them to fire. If your SA node is not working, if something's wrong with your SA node, your AV node can be the default. So remember, SA node talks to the atrial cardiac cells. And then the SA AV node fires down the bundle, wraps around the ventricles. So they're saying this AV node can take over, can be the default pacemaker if something happens to the SA node. So if this is somehow damaged, the AV node can take over. You still have enough flow of blood, you still have a high enough cardiac output, the heart is still beating fast enough to pump blood fast enough to sustain life. If it drops too low, if your heart is not beating fast enough, you cannot sustain that perfusion or blood flow to feed all of your tissues to to sustain life. They're now talking about the actual cardiac muscle cells. So it's kind of like, here's the node. This node's going to generate an action potential. That action potential is going to spread to the actual cardiac muscles that are going to do the contracting, right? These are the ones that are actually going to contract. We're going to see sodium, potassium pumps, calcium pumps. We're going to see some channels for both sodium and potassium. The resting membrane potential is a little bit lower here. So remember, the node went from negative 60 to positive 1.2 millivolts and then went back to 60. When it generated the action potential, that action potential initiated the cardiac muscle contraction. So the muscle cell was at negative 90. We're going to see it go up to positive 30, 35, and then it's going to go back to negative 90. And this is where we're going to see contraction, right? The action potential generated in the cardiac muscle to cause contraction. So there's fast gates, there's slow gates. I think it's better to look at the images and kind of walk through the basics. What's still there? What's similar? How are nodes and cardiac muscle similar? And then we'll talk about how this is different compared to skeletal muscle. So here's the cardiac muscle at rest. They're showing you a sodium gate, they're showing you a potassium gate, and they're showing you a calcium channel. So during depolarization, the impulse from the conduction system opens the fast sodium channels. The major point here is that sodium is entering and changing the membrane potential from negative 90 to positive 30. So the conduction system, they're saying the SA, AB node, bundle, right, Purkinje fibers, some action potential triggered from those is now opening sodium channels in the cardiac muscle that's going to contract, and that's changing the resting membrane potential from negative 90 to positive 30. Then we're going to see this phase called plateau. We haven't seen this before. We usually see depolarization and repolarization. This plateau is when we're going to see calcium channels that are going to open. So it's saying potassium is leaving a little bit. There's some calcium channels. There's still depolarization. So the key player here is that calcium is entering. Do we still have some potassium leaking out? Yes. But kind of the main player here is calcium is entering into these cardiac muscle cells, and it's extending contraction. It's kind of like holding contraction for a second. Then repolarization happens. We're going to see the calcium gates close. We're going to see the potassium channels stay open, and the membrane drifts back down to its negative 90 resting membrane potential. So here we are at negative 90. Depolarization is going to happen because sodium is flowing in. We have this extended plateau phase because calcium is flowing in. Potassium is going out, but this is kind of the game changer. This calcium channel opening and calcium coming in has this extended contraction phase. And then we have repolarization, where we now see the outflow of potassium from the cardiac muscle cell. So hopefully we're okay with the terms polar. So resting membrane potential, the inside is negative 90, the outside is positive because there's sodiums out here, there's calciums out here, right? So we say that a muscle cell is polarized. It's positive on the outside, it's negative on the inside. When we let these sodiums in, we go from a negative to a positive inside. The outside is still positive, so that's why we call this depolarized. Was it polarized? Positive outside, negative inside, yes. What did we do? We depolarized it. Now both sides are positive. Then we take this potassium and we kick it out. Outside is still positive. Inside goes back to negative, so we call this repolarization. So I would make sure that these terms make sense to me and that I kind of have some ideas in my head about what's happening during depolarization. So during depolarization, sodium's flowing in, the sodium channel is open. What's happening during the plateau phase? Calcium channel open. What's happening during the repolarization phase? Potassium channels are open. So I think of depolarization as getting ready to contract. The plateau is where we're generated an action potential. We're actually telling the cells to contract, right? Remember, we'll see a slide in just a second, but this is just the first phase. We've just told the muscle that it needs to contract. Now we have to do something to the myosin and the actin, right? We have to get that cross-bridge cycle going to actually do contraction. So depolarization, we're generating an action potential. Plateau, we're holding the action potential. And repolarization, we're relaxing. So then the mechanical events have to happen, the cross-bridge cycle. So calcium is going to enter from the interstitial fluid, leading to contraction. Just like in skeletal muscle, when we had troponin, we had the calcium bind the troponin, and it moved the gate, the tropomyosin gate, and initiated that cross bridge where we have the myosin head reaching up, grabbing the actin, and pulling that power stroke, right? And then as the calcium levels decrease because the gate closed, that's going to trigger relaxation. Cardiac muscle cannot exhibit tetany. I'm going to show you the image in just a second. If you remember tetany as kind of building tension. Unlike skeletal muscle, cardiac cells have a long refractory period. It contracts, holds, relaxes. Contracts, holds, relaxes. A cell cannot fire a new impulse during the refractory period. The heart cell contracts and relaxes before it can be stimulated to contract again. So maybe you remember this image of tetany, this wave summation from 201. So here, these are all stimuli, right? We say contract, it depolarizes, it generates an action potential, and then just as it's starting to do repolarization, we send another message from the brain, contract again, contract again, contract again. So the muscle can never come back down to its resting membrane potential. What are we doing? We're trying to develop tension, right? We're trying to have enough tension to exceed the load that we're trying to lift. They're saying heart doesn't do this. Cardiac muscle cells don't do this. We don't build tension in our heart. We tell the ventricles to contract, they hold for a second, that's the plateau, and then they relax. I like this image because it is showing you the depolarization, the plateau, and the muscle contraction. I like it better when they show it compared to skeletal muscle, but you can see here, this is the depolarization quick, plateau we hold, and then finally repolarize. So what they're trying to show you in this period is this is the refractory period. You cannot make a heart muscle contract again when it's in the middle of this contraction phase, right? So there is no building tension. It has to relax before it can be told to contract again. Similarities with skeletal muscle. Muscle contraction is preceded by depolarizing action potential. So what they're saying is you have to have some sort of action potential trigger skeletal muscle and cardiac muscle. So in skeletal, we had our neuromuscular junction, you had your synaptic knob, release acetylcholine, right? There was an action potential from the brain that triggered that release of acetylcholine, and then it bound the acetylcholine receptor on the skeletal muscle, and it initiated an action potential in the skeletal muscle. So they're saying in cardiac, it's the same way. We have that node. That node is going to generate an action potential, and that action potential is going to trigger an action potential in the cardiac muscle and cause it to contract. So same kind of setup. One action potential is going to cause depolarization in the skeletal muscle and the cardiac muscle. Depolarization travels down the T-tubule, causes calcium to be released. We have that excitation contraction coupling. We're going to see calcium bind the troponin and cause the filaments to slide. That's when the myosin head reaches up to the actin fin, and we're going to see that power stroke pull. The difference is some cardiac muscle cells are self-excitable. Those are the nodes we keep talking about. The heart contracts as a unit. The influx of calcium from extracellular fluid triggers the calcium release from the sarcoplasmic reticulum. So extracellular calcium, when it enters, and that causes that plateau phase, right? That calcium entering is what actually triggers the internal calcium, right? The calcium, the intracellular calcium from the sarcoplasmic reticulum to be released. Is it still going to bind the troponin? Yes. Is it still going to trigger the tropomyosin gate to move and the filaments to be able to reach up and touch each other and do the cross bridge? Yes. So all that's the same. They're just saying that the outside calcium coming in is what triggers the release of the inside calcium. There is no tetany, there is no building tension in cardiac muscles, and the heart relies almost exclusively on aerobic respiration. So remember, skeletal muscle can do anaerobic, you can generate lactic acid, you can kind of do the holding pattern where you're just generating 2 ATPs. So go back and look at the difference between aerobic and anaerobic. If you missed that in 201, there's some videos in the link on the other 201, my other 201 YouTube playlist, and you can watch, I think it's chapter 10 from this same textbook, this McKinley textbook, that you can read all about aerobic versus anaerobic if that's not making sense to you. So basically, your heart is very vulnerable to interruptions in oxygen. So remember, anaerobic respiration, it means with oxygen, and it's where you take 1 glucose and you're turning it into 36 to 38 ATPs. The next topic we need to cover is the ECG. So the ECG, sometimes called the EKG, depending if cardio is spelled with a C or a K. You can see a P wave, I have highlighted, a QRX complex, and a T wave. So the P wave has to do with atrial depolarization. So think of depolarization, you should be thinking of sodium inflow or influx into the muscle. You should be thinking about generating an action potential. You should also be thinking contraction, right? They're getting ready to contract. The atrial muscles are getting ready to contract. Then you have a QRX complex. This is ventricle depolarization. And then you have the T wave, which is ventricle repolarization. Again, when you hear repolarization, you should think about the potassium leaving, right? So outflow. You should be thinking relaxation. Also here you could, if we're talking about cardiac, you could also be thinking about the influx of sodium and calcium. There are segments between. I think the image does a better job of showing you those. They do correspond to specific phases of heart action potentials. So we'll see those in just a second. Here's our P. Here's our QRS, and here's the T. So we said this is atrial depolarization. This complex is ventricle depolarization. And this one is ventricle repolarization. Basically, if we're talking about cardiac muscle cells, did we say they start at -90 resting membrane potential, right, millivolts? Goes up to +30, and then when it does repolarization, it goes back to -90. Can we measure these electrical differences? If I put specific leads on you that can measure these, can I put them on you? Can I take all this information and can I put it into a graph form that it shows the activity, the electrical activity of your heart? So it's basically what we're looking at. So you're going to see a little P, this increase is showing you what's happening with atrial depolarization. Then QRS is showing you ventricle depolarization or contraction, and then T is showing you ventricle relaxation. In this image, we're trying to isolate what's happening in the atria versus what's happening in the ventricles. So they're showing you the depolarization of the atria, then they're showing you the plateau, then they're showing you the repolarization. So that's happening in the atria. So that's why this little P right here, atrial depolarization. The ventricles, they're showing you the depolarization, the plateau, the repolarization. I'm not sure if you can see this here, but do you see how the repolarization of the atria is masked by the depolarization of the ventricles? That's why we don't have atrial repolarization on the EKG. So are the atria depolarizing, doing plateau, doing repolarization? Oh, there's a T missing, right? Are the ventricles doing depolarization, plateau, repolarization? Yes. What can you see? The P wave, atrial depolarization. QRS wave, ventricle depolarization. T wave, ventricle repolarization. We cannot see the atrial repolarization because it's hidden by this ventricle depolarization. Again, just walking you through it, they're showing you atrial depolarization. They're showing you this segment, the PQ segment is the atrial plateau. Then they're showing you the QRS, which is the ventricle depolarization, and they're telling you that the atrial relaxation is hidden. So it would be behind this, but we can only measure electrical differences, right? So then we see this ST segment is the ventricle plateau, and then we see ventricle repolarization in T. In this clinical view, they just want you to realize that sometimes something could be wrong with the heart's electrical activity, right? You could have impaired conduction. Something is not working, the message is not being sent properly, and we can see some of that on these ECGs. So I usually talk about, here's my P wave, right? And then we have the QRS complex, and then we have our T wave, right? What happens if you had a lower P? We know this automatically has something to do with atrial depolarization, right? So atrial contraction. So if this was smaller or absent, there'd be something wrong with atrial depolarization. Maybe you're going to automatically think there's something wrong with the SA node, right? QRS has to do with ventricles. So you could have, if normally it's supposed to be this, and all of a sudden you have somebody that has this QRS, oh, that's telling you there's something wrong, right? It's not contracting as forcefully. So you can look through these. You could look and understand just kind of the basics of the PQRST and what it means, and you'd have at least a little bit of an idea if something is wrong. Again, this is a specialty. You'd have to learn a lot more. There's some really cool medical Twitter sites that you can follow. So I have one that's on cardiac conduction, and so they'll post EKGs and like, hey, what do you think's wrong with this? So there is some stuff out there that's kind of fun medical trivia if you wanted to learn more about what an ECG looks like, what an abnormal one looks like, what it means. There are also some cases where you're going to have premature ventricle contractions. So they're not following the normal pattern, right? So there's some sort of abnormal action potential, and that action potential with the AV node or the ventricles is causing the ventricles to not contract in sync. And so this chaotic timing is called fibrillation. So either your atria are in fibrillation or your ventricles are. This is much more serious, right? Because this is pumping blood to the pulmonary trunk to exchange the carbon dioxide and oxygen, or from the left side, we're pumping to the aorta to feed our systemic tissue, right? So this is where that term defib comes from, right? So if somebody is in fibrillation, it's uncoordinated contraction, your heart, your pump is not working properly. This can lead to death of heart cells. Imagine if you're not getting oxygenated blood into the aorta. Remember, the first two offshoots of the aorta is the left and the right coronary artery. They're feeding the heart muscle. So you can imagine if you're not having proper contraction of the ventricles, you wouldn't get blood flow into the aorta. This could cause heart cell death, right? So we're going to use the paddles, I'm sure we've all seen on TV, and we're going to defib the patient. The next overview I'm going to kind of go through briefly. You'll see in just a second, I would look at the events of the heart from the start of one heartbeat to the next and look at which valves are open and which valves are closed. So we have the contraction phase, which we call systole, and then we have diastole, which is relaxation. Most of the time, we're talking about the ventricles. So remember, the atria are on top, and they kind of get a gravity assist. So let's say there was no contraction of the atria. Is gravity going to cause the blood to flow into the ventricles? And hopefully we're all saying yes, right? So really what's important, what's the most important is, are these ventricles contracting forcefully enough to push blood out to the lungs to exchange carbon dioxide and oxygen, or is the left ventricle pumping enough to send oxygenated blood to the aorta out to feed your systemic tissue? So we're really kind of, even though we're talking about the entire heart, we're really focused on the ventricle contraction. So when the cardiac cycle begins, the four chambers are at rest, right? Blood is coming back to the heart, to both atria. So I know a lot of times we learn one side first, then we learn the other side, but everything is filling at the same time. So blood is coming from the superior vena cava, inferior vena cava. You also have your coronary sinus, and blood is filling into the right atrium. You also have blood returning to the left atrium from those pulmonary veins. So both are filling up at the same time and dumping into the ventricles. They want to make sure you realize that the AV valves have to be open and that the semilunar valves have to be closed. So it makes sense, if blood is flowing from the atria to the ventricles, your bicuspid and your tricuspid have to be open. These semilunar valves are closed. So next, you're going to have the SA node that's going to fire. You're going to have the atrial contraction happening. It's going to push the remaining blood from the atria into the ventricles. And when the ventricles are filled with blood, we call this end diastolic volume. So end rest volume. So remember, the ventricles are at rest right now. They have not contracted. So when the ventricles are filling, when the ventricles are at rest, that total volume is called end diastolic volume. Next, we're going to see that the Purkinje fibers are going to activate that ventricle excitation, right? So we have the AV node, we have the message travel down the bundles, the Purkinje fibers, and they're causing the cardiac muscle cells in the ventricles to contract. The pressure is going to rise, and that's going to cause these AV valves to close. So the ventricle pressure is still less than the pressure in the trunk, so in the pulmonary trunk or in the aorta, so these semilunars stay closed. So the AV valves are going to close just for a short period here, the semilunar valves, because we're just starting contraction. The ventricles are going to continue to contract, so we're kind of building up pressure here. So when the ventricle pressure rises above the arterial pressure, what are they talking about? The ventricle pressure has to be above the pressure of the blood that is currently in the aorta and the pulmonary trunk. The semilunar valves are forced open. The blood is going to move into the aorta and the pulmonary trunk. End systolic volume is the amount of blood remaining in the ventricles. So your ventricles do not contract every drop of blood up and out. Some blood is still remaining in the ventricles. The amount of blood that we eject is called stroke volume. So end diastolic volume, this is the blood that we put in. The end systolic volume, blood remaining So therefore, stroke volume is blood ejected. And this is the image that corresponds to that ventricle ejection. So we can see the ventricles are contracting forcefully. We're pushing blood into the pulmonary trunk and the aorta. You can see the semilunar valves are open. What else do you notice? The AV valves have to be closed. We do not want backflow, right? Backflow, bad. So the AV valves have to be closed. So I would go through each of these. If the atria are contracting, which valves are open, which valves are closed? If the ventricles are contracting, which valves are open, which valves are closed? Here you can see when the ventricles relax, they're going to start to expand, the pressure is going to drop. You can see that there's still some blood left in the ventricles. That was that end-systolic volume. You're going to see that the semilunar valves are closed, and you're going to see that the AV valves are closed. What's really going to happen, these are going to start filling, these valves are going to be open, we're going to start the whole process over again. They're kind of just showing you a snapshot, right? This is all happening pretty fast. We're moving 5 liters of blood in a minute. Now we get to talk about cardiac output. So cardiac output is the amount of blood pumped by the ventricle in a minute. Usually we measure it in liters per minute. If for right now, you want to think of this as blood flow, that's kind of fine, right? So we're talking about the ventricles moving blood out into the aorta or the pulmonary trunk, and if it goes to the aorta, it's going to go systemically and feed all of your tissues. So if you want to think about blood flow, that's fine. We use this as a measurement of the effectiveness of the cardiovascular system. In healthy individuals, you're going to see cardiac output go up during exercise. If their heart is working properly, you're going to see more blood moving through. And this should make sense because you want to have more blood moving through as you're working out, because you want to make sure you have enough oxygen and glucose going to the tissues, because they need lots of ATP to keep contracting, right? So they give you this equation. You do need to know the equation. You need to know that cardiac output is determined by how fast your heart is beating and how much blood your heart is ejecting. So, for example, if your heart is beating 45 beats per minute and you're ejecting, stroke volume, you're ejecting 70 mLs of blood per heartbeat, that would be your cardiac output. Basically, your blood flow is about 5 liters per minute. And remember, we have about 5 liters of blood. We said that's a good average. So some variables that can increase heart rate. If we're talking about, I guess, influence in general, because we're going to talk about decrease as well, but if we're talking about increasing heart rate, oh, these pesky hormones, right? Adrenaline. Can adrenaline, we said it can increase your heart rate, it can increase your blood pressure. Thyroid hormone can do that as well. Remember, we said increase metabolism. There are some other agents like caffeine and nicotine that can increase your heart rate. So kind of think of it, cardiac output is the result of changes in heart rate and stroke volume. So if your heart speeds up, are you pumping more blood? Yes. Is your blood flow increase? Same thing for decrease. If I decrease your heart rate, what happens to your cardiac output? You decrease the amount of blood that's flowing, right? So what are some things that can decrease your heart rate? Well, activation of parasympathetic pathways, right? Rest and digest. We have some drugs, beta blockers, they block specific receptors and cause a decrease in heart rate. Remember, we also have these autonomic reflexes. So there is some play here with the cardiac center that's in the brainstem. Sympathetic, parasympathetic. This cardiac center in the brainstem can either turn up heart rate, sympathetic, or turn down heart rate with parasympathetic. We also might want to adjust sympathetic, parasympathetic pathways, heart rate, if we detect pressure differences, right? Or if we detect carbon dioxide, oxygen differences. So basically, your heart rate can go up and down based on baroreceptors, chemoreceptors, sympathetic, parasympathetic, drugs that you take, legal drugs that you ingest, or hormones released in your bloodstream. Kind of the bottom line is here, right? If you increase heart rate, you increase cardiac output. If you decrease heart rate, you decrease cardiac output. With stroke volume, which is the amount of blood injected in one beat, kind of the return of blood to the heart determines how much blood can be ejected by the ventricle. So what they're saying is, here's my right atrium, and remember we're returning all blood. So this is venous blood. When I say venous, hopefully we're making the superior vena cava, inferior vena cava connection, right? So all the venous blood, the deoxygenated blood is going to the right atrium. What they're saying is if you put less into the heart, are you going to be able to eject, or are you going to eject less from the heart? Right? If you're not putting enough blood into the heart can't make blood, right? All it does is move blood around. So your stroke volume can be affected by your venous return. The heart contracts more forcefully when it's filled with more blood, so the stroke volume increases. If you have less blood, stroke volume decreases. Stroke volume can also be affected by contractility. So remember, stroke volume is basically the blood that gets ejected. Well, what determines how much blood gets ejected? It's contraction of the ventricles. So what affects contraction of the ventricles? The amount of calcium that's available. If you have some sort of electrolyte imbalance, right? We're supposed to have sodium on the outside, calcium on the outside. We're supposed to have potassium on the inside. You change that electrolyte balance. Certain drugs. We have calcium channel blockers. So if somebody's on a calcium channel blocker, that's less calcium can enter. That means less plateau. That means less forceful contraction, right? That will mean less blood ejected from the heart. So it's all connected. The other thing that can affect stroke volume that's a little hard for us to think about is something called afterload. So this is the resistance in the arteries. So when I say artery, hopefully we're thinking aorta and pulmonary. You can call it, oh, I spelled that wrong. Pulmonary, hit it out. Pulmonary trunk. I know sometimes they just call it pulmonary artery. It's fine. I learned pulmonary trunk and right and left pulmonary artery, so either way is fine. But the resistance in these arteries to the ejection of blood by the ventricles. So again, we've got our right ventricle, our left ventricle. Right ventricle is going to pulmonary trunk, and that's going to the lungs. Left ventricle is going to aorta, which is then going to your system or systemic. So what they're saying is the blood here that's being ejected, your stroke volume, that amount of ejected blood, must exceed the pressure in the aorta and the pulmonary trunk. Basically, for this blood to move into those vessels, it has to displace the blood that's already there. So we're moving the blood from the ventricles into the aorta, pulmonary trunk. The blood that was there, we're pushing further down. So if you have any sort of plaque buildup, this is going to increase the afterload. It increases the pressure. So if I increase the pressure in the aorta, it's harder to eject blood. So you're going to see a decrease in stroke volume. We see this as we get older. There's greater resistance. So basically, this blood has a really hard time pushing up against the really high blood that's already there in the aorta. And if that happens, less blood is going to be ejected. This is an image from another book. They're trying to show you kind of everything all on one chart. So they're showing you the different actions. They're showing you this is cardiac cycle that we just talked about. And so they're showing you what happens when it fills, which part is filling, which part's contraction. So it's what they're trying to show. They're also showing the pressure, how the pressure is building. So here's atrial systole. So this is when the atria contract, right? And then they're showing ventricle. So they're showing you the pressure generated by the ventricles when they contract. They're showing you the pressure of the blood in the aorta. That's what's in green. So I'm not sure if you can see it as clearly as I can, but do you see how the blue, the left ventricle pressure, has to exceed the green aortic pressure for the blood to move into the aorta? So the stroke volume, the amount of blood ejected, depends on how forcefully the ventricles contract and the pressure that's currently in the aorta. The other factor is how much blood you add, right? The venous blood return. If I put less blood in, I'm going to get less blood out. That's just how it works. So kind of putting it all together, we're talking about cardiac output, and we're saying cardiac output is the result of heart rate and stroke volume. And then we're talking about which things can affect both heart rate and stroke volume. So if you have any sort of agent that is increasing heart rate, right, sympathetic, epinephrine, norepinephrine, or you can have a negative agent that's decreasing the heart rate, like parasympathetic, or you have some sort of beta blocker drug that someone's on. Then we have venous return. We have positive agents that increase stroke volume, and we have negative agents that decrease stroke volume. And then we talk about the pressure, the resistance that's in the arteries, whether they can overcome if the ventricle pressure generated can overcome the pressure of the blood that's already in the aorta and pulmonary trunk. So go back and kind of look at this, name something. What's a positive agent that increases heart rate? What's a negative agent that decreases heart rate? If you can go through and give me one example for this flow chart, you'll be well on your way to understanding how stroke volume and heart rate can be affected. And then remember how this all ties into cardiac output, or what we would consider our blood flow. We also have some clinical terms here. If you've ever heard bradycardia, basically you have a low resting heart rate, anything below 60 beats per minute. I do want to mention that this is normal in athletes. So in athletes, their heart rate goes down, their stroke volume goes up, and their cardiac output stays around 5 liters per minute, which is kind of normal. So their heart is more efficient. Their heart is beating less. They're pushing out more blood. They're ejecting more blood from their ventricle, but their perfusion rate, or their blood flow, their cardiac output, is still similar to a normal individual. So their heart is having to work less hard. It's working more efficiently, and we're getting good perfusion or good blood flow. So what are some of the things that can cause bradycardia? You can see hypothyroidism. We've talked about this last chapter. If there's any sort of electrolyte imbalance, remember we're really dependent on sodium and calcium and potassium for the heart rate, right? For those cardiac muscle cells to contract. Tachycardia, this is a high resting heart rate, anything over 100 beats per minute. It could be heart disease. It could be illness. Remember, if you have a fever, you're going to turn up the temperature, right? You're going to have your heart beat faster. You're going to have higher metabolism. You're going to try to recover. Also anxiety, right? So the brain can send sympathetic messages. You could be releasing adrenaline. We could have your heart beating much faster than it needs to pump blood. These last couple of slides, I just want to show you that the heart, when it's developing, we'll talk more about this when we get to reproduction, but they kind of just go through and talk about what weeks do we actually see a heart tube forming, when do we see the 4 chambers of the heart, when do the great vessels form. I think this is a nice image showing you the difference between the fetus and a newborn. In development, you can see that there are several areas that are open when you're a fetus and are closed when you're a newborn. And we'll come back and talk about this when we get to the reproduction chapter. But I did want to mention the foramen ovale. So the foramen ovale is the opening in the fetus between the atria. So remember, the fetus is receiving oxygenated blood from mom. It's mixing here. We've got this moderately oxygenated blood. It goes into the right atrium, and then there's an opening, so it flows directly into the left atrium. And then it's going to come up and out the baby tissue or fetus tissue, right? So this foramen ovale is opening. It's going to close and become a fossa ovalis. So during in getting ready for childbirth, one of the initiations is for this foramen ovale to close so that the newborn, its lungs are fully functional, right? So it can exchange its own oxygen and carbon dioxide. Basically just putting into words what I showed you. Why is the blood shunted from the right atrium to the left atrium? The fetus, their lungs are not fully functional, right? So we're kind of mixing mom's oxygenated blood with the fetus's deoxygenated blood, and we're moving that moderately oxygenated blood through the blood vessel system or cardiovascular system. And it should close. For this slide, you could just look at some of the defects that can occur. You could have an atrial septum defect, where that was the one I was talking about, where there's a hole between the left and the right atrium. You can have a ventricle septum defect where there's a hole between the right ventricle and the left ventricle. That wouldn't be good. We'd be mixing deoxygenated blood with oxygenated blood. And then there are some defects that kind of seem to occur together. So you can have a septal defect, you can have a narrowing of the pulmonary artery, you can have a widening of the ventricle, you can have an enlargement of the ventricle as well. So a complicated process. We'll look a little bit more at this when we do reproduction, but certain openings are normal during the process of development that should close before the newborn is delivered, right? So I know this is hard. Kind of go back through the cardiac output, stroke volume, ask me any questions, stick to those learning objectives. Talk to you later. Bye.